Hello, and welcome to the Dance Physio Podcast, a podcast designed to explore ideas and foster discussion around dancer health and wellness. We're here to challenge the status quo, bridge the gap between dance science and the studio, and help change the landscape of the dance industry for the better. I'm your host, Erika Mayall, a dancer turned physiotherapist who is deeply passionate about leaving the dance world better than I found it. I'm so glad you're here. Let's get started. Hello, everyone, and welcome back to another episode of the Dance Physio Podcast. I am your host, Erika Mayall. Today, we are going to get into talking about femoral acetabular impingement, or often referred to as FAI, or sometimes just called hip impingement, and we're specifically going to talk about it in dancers. And before we dive in, I just want to give a shout out to my friend Leah from Performance Pilates and Rehab. She is an osteopathic doctor in the US, and she actually we were chatting online and she sort of said, hey, have you done a podcast episode about FAI? And made me realize I had not, in fact, done an episode. And I thought I had because we've done quite a few episodes on hip stuff. And she made me realize I had not done one on FAI. So that is where the inspiration from today's podcast came from. And as always, if you have a condition or a topic or anything that you are interested in hearing more about or hearing my opinion on, feel free to send me in suggestions at any time. I'm always looking for ideas of what is going to be most useful and usable for you, the listener. So I am always taking requests. But thank you, Leah, for reminding me of that. I know it's one of your favorite things to treat and work on with dancers. And so that is what we are going to dive into today. So, like I said, FAI stands for femoral acetabular impingement, or sometimes just gets called hip impingement. There are other types of hip impingement that we see sometimes in the dance population or in other populations that are more of a soft tissue impingement. So they might involve things like the hip flexor muscle or things like that. So today I am specifically talking about FAI, which is a bony type of impingement. And so what it is it is the change in the structure of the actual bones that make up the hip joint. And we'll talk about the different types in a second. And there are sort of two main causes of FAI that we see. And one of them is like a congenital structural change. And what we mean by that is some people are just born with anatomical variations that might make them susceptible to FAI, or they may actually have FAI, this impingement, as part of their sort of normal bony morphology. So there are some people where it is a structural thing that has been around forever, and in dancers it might get exacerbated, so it becomes symptomatic, but it is something that is maybe always underlying, been there from a structural perspective. The second type of FAI that we see is what we would call functional. So these are impingements or these bony changes that we see develop over periods of time, and they can be associated with things like in a dance population, the fact that we use such extreme ranges of motion and are doing repetitive movements in these extreme ranges of motion, that can leave some dancers more susceptible to developing this FAI. It can be due to some maybe non-optimal muscle activation patterns that we see. So a lot of the kind of like habitual muscle recruitment or muscle patterning that we might see in dance can lead to dancers developing this over time. And in some cases, we can actually trace it back to maybe improper or incorrect technique with certain movements or certain positions of the legs and things like that. So we have these structural FAI that people are maybe more often than not born with. And we also have functional FAI that develops from repetitive stress at the hip joint. So like I said, the FAI is a change that happens in response to stress happening at the hip joint or changes the bony morphology of the hip joint a little bit. So there are three different types of FAI that we see. And really it's two types, and then the third type is a combined type. You'll see what I mean in a second. And so the first one is called a CAM lesion. Can't speak right now. A CAM lesion. So CAM. And that involves a change in the actual femoral head. So we know the hip is a ball and socket joint, and the socket part is called our acetabulum, and the ball part of the ball and socket joint is the head of the femur. So a CAM lesion involves the head of the femur, and it is a change in the bony structure of the head of the femur that leads to, it usually looks like sort of like a little bump that forms right around it's called the femoral neck, but it's where like the roundest part of the femoral head blends into the neck, which then attaches to the shaft of the femur. And so we'll see changes in the bony structure in that area, and people will develop this CAM lesion or a bump in that area. This leads to the femoral head not being able to move smoothly within the socket. So again, the hip is a ball and socket joint, and normally we have a lot of degrees of freedom of movement within the hip joint. We can move it in all sorts of different planes of motion. We have a lot of mobility in our hip joint. But if we have this little bony protrusion on the kind of head of the femur in that area, it can stop the hip from being able to move smoothly, especially in rotational type movements. And oftentimes it will lead to like pain or limitations in range of motion. So that is the first type of FAI that we see, is these CAM lesions. The second type is what's called a pincer lesion, so PINCER. And this is sort of extra bone or like bone spurring that develops around the rim of the acetabulum. So remember, the acetabulum is the socket of the hip joint. So around the actual rim of the socket, we will see this kind of bone spurring or like extra bone being laid down. And again, in response to stress a lot of the time. When we talk about structural versus functional FAI, the CAM lesion is a more common thing that we will see, like a structural change that somebody was maybe born with, whereas the pincer lesion, I would say more often than not, tends to be more from like a functional development of FAI. That certainly does not hold true in all cases, but I would say just from like my clinical experience and what I sort of see commonly, that maybe tends to be the thing we see more often. So we have the CAM lesion being the change in bony structure of the head of the femur, the pincer lesion being the change in the bony structure of the acetabulum, and then the third type, I was saying there's like three types of this. The third type is what we call a combined FAI or a combined lesion. And that simply means that there's bony changes in both the head of the femur and in the acetabulum itself. And so it would be, you'd be able to visualize or see these changes in both parts of the bony structure. So those are sort of the changes that we see in terms of, if we're looking on like radiographs or things like that, like what is actually structurally happening at the joint. Like I kind of alluded to with the functional cause of FAI, these injuries are potentially more prevalent in dancers than they are in the general population. So there's sort of some data, and I'm sure there's different numbers in different studies, but one study that I was looking at sort of said or suggested that potentially the rates of FAI in dancers are about 23% versus in the general population, maybe more like 5 to 6%. And that does not necessarily mean that every person who has a bony structural change around the hip joint has symptomatic FAI. There are people who end up getting imaging done for other reasons, maybe not specifically looking for this, and it kind of shows that, oh, you've got a CAM lesion present or whatever, but they don't have any actual symptoms or any problems associated with it. But if we're looking at numbers from the literature, dancers versus non-dancers, like I said, kind of 23% versus like 6-ish, 5 to 6%. So definitely a little bit more prevalent in dancers than in non-dancing populations. One of the reasons why we are interested in FAI in general and kind of hip impingement in general is that it is often a major contributor to other types of hip injuries or hip issues that we see. And I think I have talked about this a little bit previously on the podcast episode on hip labral tears. So if you haven't listened to that, that was episode 75 of the podcast, and it dives all into hip labral tears. And FAI is one of the major contributors to developing labral tears in the hip. So these two topics often do go like very hand in hand. And they're not mutually exclusive. Just because you have an FAI doesn't mean you'll definitely develop a labral tear, but it is definitely a contributor. And to other issues that we see in hips as well. I think I've also talked about this a little bit on the hip episode where I talked about snapping hip syndrome. That's episode 51. So again, if you're interested in learning more about the hip in general and you haven't listened to that one, go back and listen to episode 51. I will link it in the show notes for this episode as well. But these are just a couple of the conditions that the presence of FAI might contribute to, because like I said, if we have this kind of hip impingement present, it can contribute to other issues and other injuries that are happening around the hip. So how do we diagnose FAI, or how do we know that this is what's happening? Oftentimes, it is based on our clinical assessment, and things that we might find on clinical assessment are loss of range of motion, so stiffness, and especially in certain positions. And so it might be into end ranges of like hip flexion or hip abduction. So in certain positions, if those bones are then kind of compressing into each other or rubbing into each other, we can see this loss of range of motion. We will often see muscle weakness in specific muscles around the hip joint. We might actually see muscle atrophy. So that means like shrinking of the muscles. So the muscles might actually be getting smaller as they're getting weaker. So we will often pick up on muscle weaknesses or muscle imbalances in through there. There can be presence of like clicking or catching or feelings of like the hip giving out. Some people feel like they'll almost report like it feels like their hip's going to like give out on them if they try and like put too much load through it or too much weight through it. So those can be some of the things that we can find on a clinical assessment. In terms of other symptoms that dancers will report, is often that the pain is kind of like a deep, achy feeling a lot of the time. It's usually in the front of the hip and often like very kind of almost mimics like groin pain. Like people will sort of say it's like deep in the front of my hip. It feels like it's in my groin area. And one of the other things that we see commonly, which we maybe don't see as much in some muscular issues or other issues around the hip, is people will often have pain at night with FAI as well. And that's because our bones are generally kind of metabolically active at night. And if the bone, like the actual kind of spurring of the bone or those changes in the bony morphology are inflamed at all or getting irritated, then when the bone is more metabolically active, it can give them pain at nighttime. So those might be some of the things that the dancers kind of report or describe. If you have listened to the episode on either snapping hip or labral tears, you'll know that like that clicking and popping and pain in the hip, all of those things can mimic those conditions as well. So sometimes with hip stuff, it is a little bit tricky to really dive in and figure out like what exactly is going on. So this is where it becomes really beneficial to seek out a healthcare provider who really understands dancers and kind of the extreme ranges of motion at the hip joint that dancers are utilizing. So just a little plug there for dance-specific healthcare when at all possible. And then finally, for like from a diagnosis perspective, we will often use imaging to diagnose these. So because it is an actual change in the bony structure and it's kind of this like extra bone being laid down or like bone spurring and things that are happening, this can be picked up on imaging. And it can show up on plain radiographical imaging. And by that, I mean like x-rays, or sometimes doctors will order like a CT or an MRI specifically for the hip, because if they're not sure, okay, is this like an FAI issue or is it potentially a labral tear or is it both going on at the same time or what is it that we're dealing with, they'll just go straight to ordering an MRI because it can tell us more information about some of the deeper soft tissues, whereas the X-ray is only really going to tell us the information about the bony structure, which for FAI, it is a bone issue, so it does show up on X-ray. But if we're also querying, like, is there FAI that's then led to a labral tear, sometimes they'll go straight to an MRI or other types of imaging. So diagnosis is usually made with clinical symptoms and potentially with imaging if that is deemed to be necessary. In terms of treatment for FAI in dancers, a lot of times we can treat these with what we call conservative treatment. So we can decrease dancers' symptoms and make them pain-free and allow them to be able to dance pain-free just with conservative treatment and not needing to go to more invasive options. And if that's the case, things that we're often looking at, like in a physio clinic in terms of conservative treatment, with FAI, we're often doing, or starting at least at the beginning, with some amount of sort of manual therapy and potentially focusing on like myofascial release. There's often a lot of muscle imbalance around the hip that plays a role in these injuries. And so using hands-on skills and manual therapy to address some of these muscle imbalances is often necessary, in addition to being able to change loading patterns and things like that. Because I find with FAI, if we go straight to trying to change loading patterns and think about rehabilitation exercises and things like that, but we have this imbalance and say some restrictions that are due to say like myofascial restrictions or things like that, we often don't have the effect that we want with the exercise intervention. So I do find in these types of hip issues that some amount of manual therapy is often necessary. That may or may not include myofascial release, like I sort of alluded to before. So in my practice, I am in Vancouver in Canada, and we as physical therapists or physiotherapists are allowed to use dry needling if we're certified in it in our practice. And I know that this is not the case everywhere around the world and in every state in the US and things like that. But this is an injury where I find dry needling can be really, really effective at, again, addressing some of these imbalances around the hip so that we can then start to get into re-educating movement patterns and things like that. One of the really big things with FAI is I spend a lot of time educating patients on specifically what it is that's happening within their hip joint so they can really understand the injury and understand the changes that have happened, like from a bony perspective. And part of that is because I think education and knowledge is power. And so it, makes the injury a little bit less scary if people understand what is going on and can understand it on a deeper level. But especially with these types of injuries, there are often certain positions or certain movements that we may want to limit or avoid when a dancer is dealing with rehabilitating one of these types of injuries. And I think it's really important for the dancers to understand why. Because sometimes I think if you just tell a dancer, okay, I want you to stay out of doing the splits and you can't do over splits and you have to keep your leg below a certain height and like things like that, you're not going to get a lot of buy-in from the dancers right off the bat with that. But if they can understand that when my hip goes into XYZ position, whatever position it is, and I use like my bony models and stuff and really show them so they can visualize this and say, when you're going into a split, this is what's happening at your hip joint. And can you see how these two pieces of bone end up rubbing against each other? And if you have this FAI and there's already irritation within those bones and some spurring and things like that that are happening, that's why we want to avoid these positions while we're working on healing this. And I think you get a lot more buy-in from dancers if they truly understand the mechanics of what it is that's happening. So this is certainly an injury, and not that I don't educate the dancers with all the other injuries that come through the clinic, but this is one where I think it's really important for dancers to understand the mechanics of the hip joint and how it moves in different positions and how the hip moves when you're in turnout versus when you're in parallel and versus when you're bringing your leg to the front or to second, so that they can understand what positions and movements we might need to limit and which positions and movements they can actually continue to do full out and we don't necessarily need to limit. So education is a massive part of treatment for FAI. And then we are often looking at movement re-education. And this is going to be different for every dancer depending on where their own unique imbalances are, their own movement restrictions, strength deficits, whatever it is that we're dealing with. So this is quite individual, but a few kind of global things that often come up with these is one of the things that I'm looking at immediately is a dancer's ability to dissociate the hip from the lumbopelvic complex. So what I mean by that is, can the dancer move their hip joint independently of the pelvis and the low back? And we often see dancers really struggling with being able to isolate some of these movements. And so we'll see a lot of, when hip movement is happening, the pelvis is either maybe it's anteriorly rotating, or maybe it's tucking under into a posterior rotation in certain positions and with certain movements. So we really look a lot at that dissociation of, can the dancer isolate and move the hip in isolation? And then looking at what is their control like in those various positions. So can they move through different ranges of motion and still maintain control in those areas? So that's one of the things we are definitely looking at with all dancers with this going on. And in terms of what movements that might look like or what positions, a really basic hip hinge movement. So, like a hip hinge, sometimes it gets referred to as a waiter's bow, or it's a deadlift type movement, or sometimes I'll use cueing with dancers and sort of cue it more as a flat back position because it kind of, they have a little bit of a connection to dance through that. But that hip hinging movement and being able to move the lumbar spine, or the entire spine really, and the pelvis over top of a stable femur or a stable leg and hip joint, that's one movement that I'm often looking at. And then the other position or movement that we're often looking at this control in is on hands and knees. So in a quadruped position. And in that position, again, can they stabilize through their core, keep their lumbar spine really still? And can they come into hip flexion or hip abduction or hip extension or whatever position it is? So those are two positions that, because they're not super dancey feeling positions, you'll often get good information because the dancers aren't as trained to be able to kind of cheat or mask those movements or make them look a certain way. So we're looking at that lumbopelvic hip dissociation in pretty much everybody who's coming in with hip impingement. I am always looking at a dancer's use of turnout, and a lot of the issues that we see in hips in general, and I've talked about this on some of the other hip episodes as well, but certainly holds true for FAI as well, is if a dancer is not utilizing their turnout really efficiently, and so maybe they're overly squeezing their glutes when they're doing it and creating a lot of unnecessary tension and maybe some anterior shear at the femoral head by overusing their glutes, that can contribute to these issues. So we're looking at, can they access their deep hip rotators effectively? Are they able to hold their turnout with those rotators and move relative around a stable supporting leg? All sorts of different things, looking at the correct use of turnout. So those are really, really big ones. And then I'm also always going to look at hip mobility in general, but very specifically hip internal rotation. And this is a tricky one because a lot of dancers with hip impingement, that internal rotation position can be a position where they actually get a lot of that pinchy or impingement type feeling happening. But it's a super, super, super important movement for us to restore, because what we see a lot in dancers is, because we work so much in external rotation, dancers lose a lot of their internal rotation mobility at their hip, and that can be a thing that's contributing to these impingements developing in through here. So always looking at hip internal rotation mobility and ways to restore that mobility and really try and increase internal rotation mobility as a way of making sure that the hip is able to move through its full range of motion in a healthy and smooth manner. But like I said, sometimes this one can be tricky to find positions or find exercises that aren't irritating to the dancer. So this is one, like I said, really important, but sometimes we have to be a bit creative with in terms of how we're promoting internal rotation, or even starting with maybe just moving to, not a huge amount of internal rotation, and then over time being able to increase and improve the internal rotation. This is also one of the areas where I find the manual therapy work necessary and sometimes really helpful, because sometimes from an exercise perspective, all of the internal rotation exercises at the beginning can be like a bit irritating. But if we address some of these soft tissue restrictions or myofascial restrictions, we free up that internal rotation mobility enough that they can then start to really work on the internal rotation mobility. And then, of course, we are always looking at strength of all the muscles that surround the hip joint. Specifically, I'm always going to be paying a lot of extra attention to glute strength, especially glute max, because a lot of dancers maybe struggle to recruit glute max. They might use their hamstring preferentially as a hip extensor instead of utilizing glute as effectively as they could. So always looking at strength of glutes for sure, along with all of the other muscles that surround the hip joint. Hip flexors are also a really important one to look at the strength of, and especially at end ranges. Dancers are often maybe lacking strength in their hip flexor when their legs are in high extension type positions. And so we're always going to be looking at that as well. But those are sometimes maybe the things that we're looking at after we've looked at the movement patterns and restoring the mobility in the hip and those types of things. So from a treatment option, like I said, manual therapy is often very, very beneficial for these types of injuries, and especially for dancers. I often use needling because it is very effective in these cases. And then lots of education on the positions that we want to avoid to like not be exacerbating things. And then really looking at the movement pattern re-education and specifically strength of different muscle groups and all of that type of thing. For dancers who maybe are not making as much progress as we want them to through conservative treatment, there are surgical options for this as well. And so sometimes they will go in, it's usually an arthroscopic surgery, and they'll go in and kind of like shave down the little bony like out or growths or like the bony spurring that's happening in through there. They will go in and smooth that out and kind of remove those and do a little bit of a reconstruction around that area. So surgical intervention is absolutely an option, but it should always be the last case scenario, in my opinion, because so often, like we talked about, so some people are just born with this type of like kind of impingement, or the shape of their bones leaves them susceptible to it. But in dancers especially, the vast majority of people developing FAI, it is that functional FAI that is developed from potentially poor movement patterns or repetitive movements at extreme ranges of motion and things like that. And if we don't address the root cause of the issue and somebody just says, okay, I'm just going to go have surgery for it and get it like cleaned up and it's going to, rotate smoothly again and I won't have any problems, but they haven't addressed that root cause, they are very, very, very likely just going to develop the same problem again 5, 10, 20 years down the road, because the problem developed due to these sort of maybe poor mechanical loading patterns and things like that. So the movement re-education and strengthening and mobility work and all of that you're going to work on from a conservative treatment perspective is necessary regardless of whether you end up needing to have surgery or not, because it becomes a really crucial part of the surgical, either sometimes we'll call it prehab if people have done it beforehand, but then they also need to do it as rehab afterwards. And the post-surgical rehab for an FAI looks very much like what we just talked about in terms of hip movement patterns and mobility and strength and all of that type of thing. So I will always advocate for trying conservative treatment first, and then, if people are not improving to the degree that is necessary for them to dance at the level they need to dance at, then maybe they end up having to go down a surgical route. But at least if you've done all of that rehab ahead of time, then you know that you've optimized the movement patterns and you've built the strength and all of that. The recovery from surgery is going to be faster, and you're also going to know exactly what to expect in terms of how we're going to also do the post-surgical rehab, because it's going to be a lot of the same stuff. So that is, I think, everything I have to say today about femoral acetabular impingement. If you have any questions about that, please feel free to reach out. I am always happy to answer any questions. And then, like I said, there are a couple other podcast episodes about hip stuff that tie in really nicely to this. So I will link those in the show notes. Like I said, episode 51 is snapping hip syndrome and episode 75 is hip labral tears. I also talked about some of this stuff in the episode where we talked about how to stop gripping in the hip. So I'll throw that one into the show notes as well. And like I said, if you have any questions, feel free to reach out. Always happy to chat more about hip stuff. Thank you so much for listening, and I hope you have a great rest of your day.